Okay, hi everyone. Thank you for joining us today for this seminar. And I'm sure it's the morning hours in Korea, and welcome to joining us. This is a collaboration between Asia Health Policy Program and the Korea program here at the Shorenstein Asia Pacific Research Center. I would like to thank Karen Eggleston, my colleague and the director of the Asia Health Policy Program, for her work in suggesting and helping to organize this important discussion on the ongoing doctor strike in South Korea. For those who may be unfamiliar, the current doctor strike is in response to the Korean government's plan to increase medical school admission quotas by 2,000 students annually, with the ultimate goal of adding 10,000 doctors by 2035, in an effort to address the fact that Korea's aging population requires more healthcare professionals. As you may know, Korea has one of the most rapidly aging populations in the world. It has only 2.1 physicians per 1,000 people. This is significantly lower than the average across developed countries of 3.7 physicians per 1,000 people. However, in protest of this plan, South Korean junior doctors, in other words, medical interns and residents, have walked off the job, refusing to see patients. Okay, their argument is that the sudden increase of medical student intake would lead to a series of problems. It could overwhelm educational institutions and lower the quality of education, or could potentially lead to issues such as overpayment of patients, which can happen when there are more doctors in greater competition. So this has become a highly contested topic politically, and we're going to show a recording that feature one of medical students from Korea to explain their position. On the other hand, critics of the strike maintain that the junior doctors oppose the plan largely due to concerns about their own income, which could be lowered due to heightened competition if the number of doctors is increased. At this point today, about 12,000 junior doctors have left their positions to strike, leading to disruptions in hospitals across the country. Some senior doctors have begun submitting their resignations in support of the strike. While the striking doctors represent less than 10% of South Korea's total physicians, they make up 30 to 40% of doctors in some major hospitals, so the strikes have resulted in cancellations and postponements of surgeries and treatment. This issue has had an important ripple effect throughout Korean society. While a majority of the Korean public initially supported the government's proposed plan, they have grown tired of the protests and increasingly critical of the way the government has handled the issue. This, in fact, became a liability for the ruling party during last week's election in Korea, playing to an outcome in which the opposition party scored a huge victory. Even though the government has expressed an openness to negotiation, the doctors have refused. So with no sign of compromise or solution in sight, our seminar today will discuss issues related to the strike and their broader political and social implications. So once again, thank you for joining us, and hope you can enjoy our seminar. So now let me turn to my colleague, Karen Eggleston. Karen?
Thank you very much, Shin. So welcome again, everybody. Karen Eggleston of the Stanford Asia Health Policy Program. We're delighted to do this with the Korea program today. And it's part of our series this year on technology and trust. And of course, the emphasis today is on trust. We know that some level of trust is critical for any health system strategy, leveraging policy and technology for improving health and well-being and supporting healthy aging. That's why our topic today is first, do no harm, Korea's physicians, government policy, and breakdown of trust. Unfortunately, one panelist, Dr. Jing Lee of University of Washington, is ill and unable to join us today. We do not have an official representative of the Korean trainees. However, we do have multiple points of view, and we're delighted to share the views of one Korean medical student who has been active in this issue, Sojin Yoon, who is a second-year student at Catholic University of Korea School of Medicine. A few days ago, she kindly answered questions about the controversy in dialogue with two students from our own School of Medicine, Kamsing Nwangwoo and Richard Leong. So I'll briefly introduce them. Prior to arriving at Stanford School of Medicine, Kamsing Nwangwoo completed his undergraduate degree in biomedical engineering at Yale University. Now he's a third-year MD PhD candidate at Stanford, studying the role of inflammation in the central nervous system, and currently serves as president of the Stanford Medical Student Association. Richard Leong is a fifth-year MD PhD student in the Department of Epidemiology and Population Health with active research collaborations in East Asia. For 2 years, he served as the co-chair of the Stanford Asian Pacific American Medical Student Association, and he continues to lead the organization as a board member. Here is their conversation with Sojin Yoon of Catholic University of Korea School of Medicine.
My name is Sojin Yoon, and I'm a second-year student at Catholic University of Korea School of Medicine. And prior to addressing these questions, I wish to clarify that my perspectives do not represent the entirety of the Korean medical community. I am an individual medical student deeply concerned about these ongoing medical crises in Korea, seeking to raise awareness on this issue to a wider audience. So it's important to note that I do not hold professional qualifications in the medical field or any related area. Therefore, my responses will be founded on research findings and insights gathered from fellow medical students and trainees.
For my first question, what is the trainee position regarding the government announcement of increasing medical student enrollment and other recent developments?
So to encapsulate the stance of the medical community regarding the government's announcement to increase the medical student quota by 2,000 starting 2025, it is perceived that the government is providing a wrong treatment while overshadowing the underlying issues pervasive within the Korean medical system. The most important problem we should be addressing is the shortage of doctors in essential and primary care fields such as OBGYN, pediatrics, general surgery, internal medicine, etc. However, the mere augmentation of physician numbers does not guarantee a surge in specialists within these crucial fields. What demands our attention is the root causes of this shortage, primarily the absence of legal safeguards against malpractice claims, coupled with a low fee for service, and the arduous and unrelenting schedules residents have to endure contribute to the disincentive for pursuing these vital specialties. Elaborating on the first point, specialized fields such as neurosurgery and cardiac surgery involve high stakes and difficulty, which often lead to a high number of lawsuits. The absence of safety nets leaves them vulnerable to protracted legal disputes and substantial financial loss, creating an environment that dissuades aspiring doctors from entering these fields. This glaring deficiency in legal protection serves as a deterrent, steering physicians away from these specialties. Furthermore, the fee-to-service system, characterized by inadequate service fees, yields a low cost recovery ratio, standing at 78.4%. This means that more patients you see, the more you are operating on deficit. So because of this, many university hospitals do not want to provide financial support to a specialty that is spending more than it is earning. Instead, we'll invest more in non-essential, lucrative fields such as plastic surgery and dermatology to make up for the loss. Lastly, the grueling working conditions endured by residents, averaging 100-hour work weeks punctuated by 36-hour consecutive shifts multiple times weekly, hinder their educational and professional growth. Without adequate time for learning and training, residents are ill-equipped to become a skilled healthcare professional. Moreover, increasing the number of medical students must be accompanied by a proportional expansion of residency positions. Unfortunately, the government's proposal lacks concrete plans or preparations in this regard. Adequate teaching hospitals with sufficient faculty are necessary to facilitate the transition of medical students to residents and eventually practicing physicians. Without these foundational elements in place, any increase in medical student enrollment risks adverse outcomes. In light of these complexities, a comprehensive dialogue on the ramifications of increasing medical student quotas is imperative before reaching a definitive decision.
Thank you for sharing that position. And I guess on the topic of obstacles, we see that the government, as you have mentioned, claims that the medical school enrollment increase is supposed to address the doctor shortage in Korea, in which the striking doctors and students may not agree with. But what do the students and doctors believe are the appropriate and feasible strategies and perhaps timeline to address this specific shortage?
So before delving into this question, it's crucial to ascertain whether a genuine shortage of doctors exists in South Korea. According to OECD statistics, South Korea indeed exhibits a lower doctor to population ratio compared to the OECD average. However, it's important to refrain from singularly relying on this metric as a rationale for increasing the number of doctors, given the distinctive nature of the Korean medical system. It is characterized by a fee-to-service framework, paying healthcare providers a fixed fee for each rendered service, operating under the National Health Insurance (NHI) system, encompassing all citizens and healthcare providers. South Korea stands alone in its singular approach, wherein the government exercises centralized control over both the insurance mechanism and the fee structure for medical services. Consequently, it is unreasonable to be comparing the number of doctors across disparate healthcare systems. It is almost like comparing apples to oranges. Moreover, when examining the frequency of doctor consultations per year in OECD countries, South Korea emerges as an outlier, boasting the highest number at 15.7 consultations annually, underscoring the accessibility and affordability of healthcare services. For instance, a visit to an internal medicine clinic for a common cold, inclusive of medication, costs less than $8, a testament to the ease of seeking medical assistance. Hence, the real question we should be asking is, what does the medical community believe are the appropriate strategies to address the shortage of doctors in the essential healthcare specialties? This doesn't entail an outright dismissal of increasing medical student enrollment. Rather, we are simply asking to go back to ground zero and start having meaningful and inclusive conversations involving diverse stakeholders, doctors, public health officials, health economists, government representatives, and more. Foremost among the advocated measures is the establishment of realistic fees for primary care specialties to ensure their financial sustainability. Direct governmental support for these essential fields, integral to national health, is paramount. Equally crucial is the implementation of safety nets, including professional liability insurance and legislative measures to protect healthcare professionals. The doctors motivated by genuine altruism and passion working in the primary care are leaving their work because they can't simply work when none of their needs are being met or their voices being heard. To instill a sense of purpose and boost morale among aspiring physicians to pursue these demanding specialties require infrastructure and support mechanisms and the necessary means. And right now, the means are just not there. We always say high risk, high return, but the reality we are faced with is high risk, no return. So we must be addressing the systemic deficiencies to ensure the sustainability and efficacy of our healthcare ecosystem. I hope my answers were able to make you reevaluate the situation and put some thought into it. Thank you so much for listening.
Thank you.
Well, we thank the students very much for sharing those views. Now, to offer a policy and health economics perspective, we turn to our esteemed speaker from Korea. Soonman Kwon is professor and former dean of the School of Public Health of Seoul National University and has worked for over 3 decades on universal health coverage, health finance and systems, aging and long-term care in Korea and in many low and middle income countries. He's the founding director of the World Health Organization Collaborating Center for Health System and Financing and was the chief of the health sector group in the Asian Development Bank. He was the president of the Korea Health Industry Development Institute, which is an R&D agency under the Ministry of Health and Welfare. He has published widely, holding several journal editorial positions, and has served as president of leading academic associations in Korea, including Health Economic Association, Society of Health Policy and Management, Association of Schools of Public Health, and Society of Gerontology. Professor Kwon earned his PhD from the Wharton School at the University of Pennsylvania and taught at the University of Southern California before returning to Korea. And he recently received the Excellence in Education Award from Seoul National University in 2020. So thanks to those who have joined us. Please put your questions in Q&A and we'll return to those questions after Professor Kwon's remarks and a few questions from Professor Shin. So Soonman, over to you.
Hey, thanks a lot for giving me the opportunity to share my views on this very important issue. Okay, first, the issue of physician supply. I think that the issue is that whether it's the quantity or distribution. I think this is one of the key questions because as you listen to the recording, the doctors, basically they think it's not a total quantity issue, but it's rather a distribution issue. So distribution means like urban versus rural, or a distribution across different specialties like surgeries versus primary care, internal medicine. So even Korea these days, there are many doctors have practiced in cosmetic surgeries, things like that. So distribution, whether distribution is an issue or overall shortage is an issue. So my perspective is that we have both. Okay, contrary to the doctors, doctors say it's only a distribution. But I think it's both. And my perspective is that without solving the total quantity issue, this distribution issue can never be solved, right? Because we are basically suffer from a huge shortage of doctors. And even if we increase fees or compensation to some areas, to some specialties, we cannot expect that the physicians move from other specialty to that specialty because other specialty area is also experiencing shortages. So basically that's my perspective. And I can see that one of the symptoms, signs of huge doctor shortage result in we can see a huge rent, very high economic rent, very high average income of physicians compared to with that of workers. Okay? Because it's a clear sign of huge shortage of doctors, but at the same time, we suffer from this distribution. So as I mentioned, without increasing the overall supply of doctors, we can never solve this distribution. So I'm not saying it's a sufficient condition, but it is definitely a necessary condition to improve the distribution. So in other words, even if we increase physicians, we cannot expect a sudden improvement in all those issues, including distribution. But without increasing the total supply, how can you solve those distribution issues? Because all specialties, if you talk to those representatives of each specialties, like internal medicine, surgeries, no specialty area says they have enough number of doctors. So basically every specialty experience a shortage of doctors, and some specialties like neurosurgeons and pediatrics, they suffer more serious shortages. But that does not, but as I said, overall, all specialties, they suffer from shortages except for some cosmetic surgeons. Okay. This is a physicians per capita. This has already been discussed a lot. As you can see, there's a huge difference. Korean doctors, number of physicians per capita, much lower than other countries. And as I mentioned, one of the important issue is the excessive rent. And this is obvious. If you are familiar with the basic economics, the lack of competition and the monopolistic conditions and limited supply definitely result in high economic rents. Okay, so this is a remuneration, but ratio. Doctors' average compensation to the average ratio. Average wage of doctors Korea is here. But it looks like it's not a very big difference because this is GPS. But mainly, more important thing is specialists and practicing doctors. This is Korea. So self-employed doctors means that the basically office-based physicians, whereas the salaried doctors are employed by hospitals. So office-based doctors, seven times higher. They earn 7 times higher than the average wage of workers in Korea. So as I said, this is a clear. Everybody knows it, and that's why it becomes more and more difficult to get admissions to the medical school because everybody knows there's excessive, very high rent. So although doctors complain the cost is lower than the fee, but we all know that it's a very controversial issue that whether the national health insurance fee schedule is lower than the cost or not. I don't think it's lower, but even if the fee is lower than the cost, why fee is lower than the cost? Because cost is inflated. Cost is too high mainly because it is overcompensation to doctors. You know what I'm saying? Again, it's a simple economics. Because because of this high rent, shortage of doctors, high rent, overall cost structure is too high. So if you reduce the doctor's excessive compensation to a reasonable level, then the cost will be decreased, and then cost can be even lower than the national health insurance fee schedule. But currently, doctors' compensation is too high, cost is too high, so doctors complain that the cost is higher than the fee schedule. And the regional distribution is also an issue, but many countries suffer from this type of regional distribution. So in Korea, we are suffering the gap between urban and rural areas, not only in the health sector, but almost all areas, because unfortunately, we are experiencing a very rapid aging of population. Some small rural areas, they basically close down. So so it's not just a health issue. We have a huge issue of the localities, whether they survive or not. Okay. But it is closely related to this nature of a Korean healthcare system. Okay. First, it's a dominance of private sectors, like about 95% of hospitals are private. I think this is the only country among high-income OECD countries that the private sector is so dominant like this. And fee-for-service, as you all know, that as you know, U.S. healthcare system is a little bit strange. We call it outlier, but compare, in other OECD countries in Europe, the fee-for-service is mainly for some specialist services, but the majority of the compensation payment mechanism for hospitals are some kind of like a budgeting or case-based payment, but still Korea's fee-for-service is dominant. And because of this private sector domination and fee-for-service, we don't have a referral system because patient is money. And most of the practicing doctors, office-based doctors, they're all specialists. So for them, they don't want to refer a patient to big hospital. And also, if they refer the patient, it's the loss of income because of this fee-for-service nature. And another big problem is patients love big general hospitals. So even with a very minor symptoms or severity disease, then patient rush to big general hospitals. So as you know, currently about many tertiary care hospitals in the outpatient sector, the operation has been reduced by almost like a half. That means that the number of patients they treat is drastically decreased in many tertiary care hospitals. But many patients suffer, but still it runs okay. Why? Because we believe that many of those patients using tertiary care hospitals, they don't have to use those tertiary care because they don't have major severity. They should be using secondary and primary care rather than tertiary care. So this health-seeking behavior is another big issue in Korea. But anyway, because of this private sector domination and the fee-for-service non-referral system, the result is very obvious. Very high rate of increase in health expenditure. And also we are suffering. I mean, we are experiencing a rapid aging of population. So we definitely have a concern on financial sustainability of the Korean healthcare system. And in terms of the rate of increase in health expenditure, Korea is always leading country among OECD countries. So although current percentage of GDP on health expenditure in Korea is about the average of OECD, but in terms of rate of increase is the highest, one of the highest, because it's so obvious because of this nature of private sector, fee-for-service, and shortage of doctors, very high rent for doctors. And as another result is the veto power of physicians. Korea has been quite vulnerable to physician strike many times. It's not just this physician walkout. It's not the first time, as you know. Whenever, government tries to introduce something like in the year 2000, there's a pharmaceutical reform. And about 10 years ago, when the government tries to introduce the telemedicine, but they are all vulnerable to physician strikes. So we are quite used to this type of physician strike and workouts and the veto power of physicians. And another aspect is a very high reliance on trainee doctors, junior doctors, because they are cheap laborers. So they are exploited by the tertiary care hospitals. And why? Because there's a shortage of doctors. Tertiary care hospitals, they don't have enough number of doctors. So they rely heavily on these trainee doctors. And you'd be surprised that about 40% of doctors in many major tertiary care hospitals are trainee doctors. In addition, because of this shortage of doctors, many of those tertiary care hospitals, they employ physician assistant illegally. Because in Korea, physician assistant is still illegal, but because of the shortage of doctors, most of these tertiary care hospitals, they employ hundreds of physician assistants illegally still. It's a kind of, we call it, public secret that they rely on this physician assistant because they don't have enough number of doctors. And this is the share of public hospitals, like 5% of hospitals only public. It's the lowest, lowest among all OECD countries. And in contrast, the hospital beds per capita is the highest. Japan and Korea are the highest. So how can you explain this situation? The number of doctors are the lowest, but the number of hospital beds are highest. So it's very, as you can expect, very tech reliant and the minimum labor, but maximum capitals. And not only beds, but there's a huge reliance on technology and machines. And as I just mentioned, heavy reliance on physician assistant, to overcome the shortage, but still illegal because Korean Medical Association, they said we cannot accept this legality of physician assistant. So they are kind of illegal operations of this physician assistant, very high income of practicing doctors, and also at the time, very high turnover I mean, hospital-based specialists, they leave hospitals to open a clinic because of this big high income in office-based doctors. And majority of medical school graduates become board certified physicians. Okay? And they, as I mentioned, they run a physician clinic and competing with hospitals. So this is very, I mean, nature, unfortunately, is inefficient nature of the Korean healthcare system. And as mentioned by the previous interviews, it's correct that the number of doctors visit is very high, is again the highest. The average number of physician visits is about 15 times, 15 per year, per person. So it's again the highest in the world. But another very unfortunate number is that the duration of physician visits is average 3 minutes. So we have a Korean joke that you wait for 3 months. I mean, especially in big hospitals, and you just talk with the doctor for 3 minutes. So the quality of it, there are huge, very high number of healthcare utilization, but the quality of utilization is very low, only 3 minutes maximum. So, I mean, how should we solve these questions? Okay. And there's as I mentioned, it's not just the first physician veto power. We have a major physician strikes against the pharmaceutical reform in the year 2000, and as a result, government increased the fee by more than 40% in 1 year, and as a result of that, Korean national health insurance become bankruptcy. So we have a minus, depleted all surplus. So it's a big historical thing at that time. Of course, I wrote a paper on that, but it's a huge increase in physician fees. And most importantly, we even reduced the medical school admissions by 10% after these physician strikes. Can you believe it? So we suffer from this decrease. I mean, many countries keep increasing the number of doctors, but Korea even decreased the number of doctors by 10% at that time. And there is a government trying to introduce telemedicines in the year 2013, about 10 years ago, but doctors strikes and government gave up. And telemedicine is still illegal until very recently. And telemedicine becomes legal temporarily because of this COVID-19. And in the year 2020, during the pandemic, again, government tries to increase the number of doctors by 400 or 500, and that range. Again, there is a physician strikes. Trainee doctors again left the hospital. Medical students refused to take national license exam. So government withdrew policy and later provided students with opportunities to take the license exam later. So they declined to take a national license exam, and then government gave up and gave them another opportunity to take the national exam. And at that time, the amount of increase only like a 400, 500 level. So you should clearly understand that the Korean Medical Association and many of the doctors' position is not about this 2,000 increase. They are basically against any increase in the doctors. That's the official position of KMA. KMA even to say that Korea is experiencing a oversupply of doctors. So that's the position of medical society. It's not about 2,000, okay? As I said, in the year 2020, government tries to increase only 400, and doctors strikes. So please understand, it's not the 2,000 is not their concern. They are concerned that any increase in doctors is wrong. That's the position of the medical society. So, as I said, KM's position is always the same. No need to increase the physician supply. And they refuse to participate any policy discussions. This is a very important point because they complain that doctors doctors were not invited to participate in the discussions, but whenever there is a discussion on doctors, the discussion to increase the supply of doctors, they don't join because their official position is that they do not accept any increase in doctor supply. And recently one of those former KMA presidents openly says that the government can never win the petitions. And it is true because in the history, doctor always they successfully push the veto power. And this time, physician clinics do not join strikes, but as I said, many big general hospitals are only partially functioning due to this workout of junior doctors. But as I said, if Korea has enough number of doctors in big hospitals, and they don't have to rely on trainee doctors, okay? So, but they don't have enough number of doctors, so they have to rely on trainee doctors. No hospital in the high-income country rely on trainee doctors for like a 40%, 40% of doctors in major tertiary care hospitals are trainee doctors, junior doctors. It's not acceptable in other countries. But Korean hospital, that's the norm because they don't have enough number of doctors. Politics are very important. This is, again, it become very popular policy because to increase the number of doctors is a typical policy supported by progressive political parties, the current opposition party and previous ruling party, like a previous government. So the current opposition party, they failed this policy like when they are ruling party. So now this policy is pushed by conservative party. So it's a kind of, as you know, you call it paradox in politics. Like the increase in the physician supply is a typical policy of progressive party in Korea. But suddenly this government, conservative government, push this policy and get a big consensus, support by opposition parties and general public. So Korean Medical Association is very disappointed because Korean Medical Association is typically a strong supporter of this conservative government. But in terms of reversibility, government already allocated the 2,000 increase in medical school admissions to each medical school, mainly in the non-Seoul metropolitan area. So already strong supporters are created. Like those many medical schools, they are already given this increased quota of student admissions. But you should know that majority of the medical schools in Korea, they are very small size. Class size is less than 100. That's again very strange case because in most countries, medical schools class size is big enough. So that's why one of the reasons that the government think that even if we increase this medical school admissions by a big margin, it should be okay because they allocated those increased quotas to many of those medical schools whose class size is already too small to enjoy the economy of scale. And also there's the leadership guide issues of this new government. But it's very important to understand there's a lack of consensus among providers. As I said, KMA and Association of Trainee Doctors, their position is very strong. Not just one more doctors is not acceptable. And KMA says Korea is even experiencing an oversupply of doctors. So their position is very clear. Not a one single more doctors is not acceptable. Whereas the Korean Hospital Association, of course, they support it because currently they pay huge, very high salaries, compensation to doctors because there's a huge shortage of doctors. So Korean Hospital Association is supporting this policy, although they don't speak it publicly because they don't want to be, demonized by Korean Medical Association. It's not a formal association, but like quasi-association of medical school professors. Their position is a bit in the middle size. They say, okay, we need to increase the number of doctors, but 2,000 is too much. So like 2 months ago, one representative of this association just privately remarks that 400, 500 doctors increase is acceptable. So there's no consensus among medical society on this issue. Governance, another big issue is that the position of doctors. Doctors still think that the shortage of doctors or supply of doctors, this policy should be decided by the discussion only by government and medical society. This is a big difference because they say that government should get endorsement from the medical society. But we cannot accept it. How come the human resources policy should be endorsed by the professionals, as you can say? Okay. I mean, no other professionals like lawyers, dentists. I mean, when government has a policy, the policy is made with the consultations of general public, many of those public issues, not solely with those professional group. But doctors, the medical association strongly maintain that this policy should be discussed solely with the medical community and endorsed by the medical community. That is not acceptable, I think. Okay. Nurses, there is as I mentioned, they have a politics associated with this physician assistant, because most of these physician assistants are medical, I mean, the nurses. And with the general election and present party, it remains the minority. And then after this election, I mean, the election campaign, the present party, ruling party kind of defeated, and they still remain a minority party. But like yesterday, the president announced that this policy of this physician supply will stay the same. There will be no change. And as I mentioned, that there are many remaining issues, because physician supply is a means, not the ends, to improve the health policy system, performance. Government already increased the fees and incentives, and actually government already announced that there's big reform in the malpractice issues. So I think malpractice is no more an issue. There's government already changed the policy, in a sense, changed the policy too favorable to doctors. So there are already oppositions by patient groups, because they say this malpractice change, I mean, policy change is at the expense, at the sacrifice of patients. But again, there's already change in government policy. So I'm a bit worried that with this physician supply policy, government has been increasing fee already too much since this. And this Y2000, it can be a controversial issue. I mean, everybody knows that 2000 can be controversial. But as I mentioned, then does it mean that if government suggested like a 500, is it going to be accepted by medical society? Is it going to be no physician workouts? I don't think so. I don't think so. As I mentioned, in the previous government did try to increase by doctors by only 400. It was, again, physician strikes, the same. So the number is not 2000 is not the key issue now in this whole issue, because doctors do not like any increase in doctors. So in a sense, but the 2000 sudden increase might be better than the incremental increase, because incremental increase may introduce so much politicking and social cost. And as I mentioned, distribution issue, especially urban, rural area is an issue. And some very progressive civic groups, they maintain that simply increasing the supply would not solve this distribution. In other words, they support the policy that there should be like 1 or 2 medical schools that specifically designated for training doctors who are going to be working in the non-zone areas. But there are very controversial issues. There might be a stigmatization. And I was in one of those 2 medical students, one of them is working the MD PhD. When I studied in the US, I have many friends in the area of MD PhD. But in Korea, no. I was the president of a government agency, and one of those programs is the MD PhD program, but it's not successful. Why? Why MD PhD program in Korea is so unpopular, so natural? Because clinicians become so high returns. You can never compare. Okay? So without solving this huge economic returns to the medical society, we can never solve the other issues. So we have been working on this MD PhD programs for a long time, but no, almost a failure so far. Okay? And also, if we increase the number of doctors admissions, then it might be a short-term impact in the quality of students going to science and engineering, because even now, there's a majority of those students, they want to go to medical school because it's so profitable there. So many professors in the science and engineering, they are worried that if there's an increase in medical school admissions, then it might damage those the science and engineering programs. But I think in the long run, if the economic rent of physicians is stabilized, then it might have a better impact later. I think this is the last one. Sorry, I'm speaking too much. And then I said that there's a word I'm worried about the sustainability of the issue, because currently too high healthcare utilization. So we need to control this utilization and change the help-seeking behavior, and obviously change the payment system. Okay, it's not just the issue of whether fee is high enough to cover the cost, but as long as we have a fee-for-service system, you can easily expect that demand inducement. And as I mentioned, the Korea and probably US. So, I mean, with these exceptions, all other countries in OECD countries, they mainly rely on other types of payment system in hospitals. But in Korea, still, the majority of the hospital payment are fee-for-service. Okay, so we should change these issues. And also government should really re-regulate the staffings in general hospitals. It's currently the tertiary care hospitals are mushrooming. So they exploit the trainee doctors because the staffing condition, the regulation is too low. So government should tighten this regulation, because government did not tightly regulate the staffing because there's obvious a shortage of doctors. So government should increase the number of doctors and tighten this staffing requirement. That's the issue. And trust is a very important issue. I know physicians do not trust government, but sorry, the public do not trust the doctors either. Because this time, trainee doctors, they left even essential care. As you know, there are physician strikes in other countries, but in the strikes, they still keep the emergency room and ICUs. But in the case of Korea, when there is a physician strike, they can easily leave the even ICU and emergency room. So in that situation, how can the public trust doctors? Over. Thank you.
Thank you so much. And to start some discussion, perhaps Giwook, you'd like to ask some questions?
Sure. Thank you, Dr. Kwon. And it's really illuminating, but also kind of depressing, because I've been following this story. And then I don't know what's going to happen in the end. But before that, let me ask this question. I mean, you're experts of public health and policy. And if you had, maybe, time with President Yoon Suk-yeol, when, what would you advise? Because, this is a very complicated, issue. And, they've been on strike for now, about 2 months or maybe more than that. So what would you suggest as a solution to the current situation? And along the line, is it option to import doctors and nurses? Okay, so here in Palo Alto, which is a very affluent area, if you go to doctor's office, there's a good chance that you're gonna see Indian doctor with a Filipino nurse. Okay, we are kind of joking, but it's quite true. So, obviously, Korea is not good in, importing skilled labor, overall. But given the situation, then, as you mentioned, if government fails again, I don't know whether they are really, ever able to increase number of doctors. And then, what about like importing doctors and nurses as a long-term solution? So if you can, make comment on that, that would be good. But overall, what's your suggestion for solution?
Hey, thanks a lot. I have nothing to do with the current government. I heavily criticize other policies of this government. But I'm a strong supporter of this policy. So I think that the government should go ahead, but 2,000 is too much. So government should show them to the public that okay, we are willing to do not want to stick to the 2,000. But I think government already said that, and government, as the medical community, please present your view. But as I mentioned, KMA, KHA, they all have all different ideas. There is no unanimous view. But anyway, 2,000 is too much. So government should reduce the 2,000. Maybe it's 1,000, and then the government should withdraw the threat to impose a legal penalty on the worked out residents. I mean, we should be, willing to give some excuses. And but other ways, I think, as I mentioned, we have a definite shortage of doctors, but there are many factors that results in the even worse situation of physician supply. For example, telemedicine is not activated. It has been illegal for a long time. So we should legalize telemedicine. It can increase the physician access. We can legalize physician assistant because they are already there, but they're still illegal. So those governments should implement some policies that can contribute to improving the access to healthcare, along with these physician supply policies. And the import is not I fully agree with that. And US is lucky because, I mean, there are so many people around the world who speak English. But in the case of Korea, there are not many non-Koreans who can fluently speak Korean. So that is an issue. But I think as I mentioned, this kind of veto power and strike is not the first time. And if government withdraw again this time, then I think it's a lot of huge credibility, trust issue for the government, and also all future policy. There will be no future health policy in Korea because in this situation of the 95% of hospitals are private, most of government policy may definitely have a tension with the medical community, but whenever medical community opposed, then government cannot do anything. So I think this is it's a symbolic value. And I mean, ruling party, president party already lost the election. They have nothing to lose more. So I think they should go.
Okay, so you also point out this issue of distribution of doctors. And last summer, we were staying at Gangnam area, and then my wife was not feeling well, so we are looking for internal medicine doctor. And then we talked to front desk in the hotel. Then, so within like a 10-minute walking distance, I'm not exaggerating. So there were about 50 doctors, clinics, and hospital, but there's no single internal medicine. All of them, without exception, either plastic surgery or dermatology, and all those those doctors, but there's no internal medicine. So we have to really go much further. So I mean that seems to be, I don't know, it's maybe a little more unusual case in Gangnam area. But I guess overall, as you mentioned, this is a big question. So how are you gonna handle that sort of unequal distribution of doctors? I mean, we know disparity between Seoul and other area, but doctors, this seems to be a very serious issue.
Yeah. So distribution is a serious issue, but as I mentioned, without increasing the total number of doctors, we can never solve the distribution. But increasing the supply of doctors is not an automatic solution. So with the increase in supply of doctors, we should also need additional policy measures. But even in that case, we cannot stop doctors mushrooming in Gangnam area because Gangnam is so profitable. So there are some extent that we cannot solve, but increasing the number of physicians will be the first step. It will be the first important step to change it, to improve the distribution issues.
Okay, so let me ask a final question that you can turn to audience. So in the end, what's going to happen? Are we optimistic or pessimistic? Based on what you're saying, it's hard to be optimistic about solution in the end. So if the government fails again, which is likely, seems like, as you mentioned, then they're going to lose credibility. And I don't know, is there any reform is possible ever?
Yeah, it's a difficult question, but for this one, I think I have some hope because there is a very high level of public support still. I mean, of course, there's a fatigue because this is taking longer than expected, but still that many of those non-severe patients, they change their health-seeking behavior and use more of those secondary level hospitals. some experts even joke that it can be a good opportunity for the general public to realize that we can still survive without relying too much on those tertiary teaching hospitals. But there are a lot of uncertainty. But I think I'm not pessimistic because, as I mentioned, the election is over, so government can push forward. And recently, it's very strange that Korean Medical Association and the Trainee Doctors Association, they openly remarked that without punishing those Vice Minister of Health, they do not want to talk, they do not want to discuss about this issue. But so very, very narrow, they are still focusing on some very specific, narrowly targeting some government officers. I don't think it's good, but overall, I think I'm not pessimistic on this issue.
Okay, great. So back to Karen.
Great, thank you. So we've had a question coming in regarding the income of Korean physicians. How would Korea's remuneration of physicians compare to US physicians? Because that was not on your graph. Any thoughts on that?
I think that I don't have the figure, but all I have is that it's not first, it's more important to compare the average doctor's new compensation compared to the average wage of workers, because it's not just the absolute level of compensation, but your level of compensation compared to others. That is more important measures. But I'm looking at this figure again, but in my data, there's no information about the US. So I'm not sorry, I cannot tell any evidence. But I can only say that.
I might say one of my colleagues, Maria Polyakova, and colleagues have extensive paper on US physician income for those interested. I also wanted to ask Soonman, maybe if you could talk a little bit about some of the other issues that were raised by the students, including the issue of malpractice insurance or regulation of trainee work hours. Do you think any of those points would be a useful part of the solution?
Yeah, I think the government already changed the policy. And then, as I mentioned, there's some revision of the policy for the malpractice litigations. So I think there's a big improvement. This is already announced, actually. So as I mentioned, of course, some doctors are not fully satisfied, but some patient groups are criticizing this policy, and they're saying this new policy to make doctors too immune to their mistake. So you can see there's different views, but government already changed the policy along with this the announcements of the policy to increase the doctors. So I think the malpractice litigation, I think is not a big issue, and I think more importantly, as you mentioned, the second issue of the regulation of the staffing requirement for the tertiary care hospitals, because now Seoul metropolitan area, they are becoming a black hole to observe not only economic, social, but also health issues. Many increasing number of patients from non-Seoul area, they're rushing to Seoul. And in response to this patient demand, many university hospitals, they are establishing a new branch university hospitals all surrounding Korea, surrounding Seoul. It is possible because the current staffing law is too loose, because we definitely have a shortage of doctors. So if government increase the staffing regulation, we can stop those mushrooming of tertiary care hospitals in the surrounding neighbors of Seoul. So I think that is very urgent, but that part still there is little change now. But without
Thank you. We have two more questions related to the issue of public trust. Maybe we can wrap up with those. So first, thank you for your presentation. There's a question about public trust in doctors. You mentioned that doctors do not trust the government. The public does not trust the doctors either. But the public doctors do not trust doctors is meaningful. How do you pressure doctors? How do you think we can persuade or bring doctors to a discussion with the government and at the same time with the general public? And just to add on to that, a second related question is about the doctor's voice, saying, as Korean residents leaving a hospital has seen a break of trust, how do you suggest they voice their opinions while they're also working 100-hour weeks?
I don't have a clear answer, sorry, but currently it seems that we joke that it's very rare that it's not just junior doctors, but medical school students join this kind of thing. And it's not just this time, even like 4 years ago, at that time, it's very, I think really it's not, so I mean, I would like to criticize the practicing doctors, because practicing doctors, they don't move. 4 years ago and this time, practicing doctors, they criticize government, but they not move. They still practice, they operate. But rather, trainee doctors and medical students, they move. What kind of system is this? I think, and in a sense, we think that they exploit, and instead of being on a strike themselves, they kind of motivate, encourage the young doctors, even students, to go to the front line, to be against the doctors. I think, in a sense, there should be some change in mindset of doctors, medical school education, because student level, I'm not sure why students are so keen to this kind of thing. So in a sense, there should be there can be an opposition from practicing doctors, but it's very rare, I think, that there's opposition and the students decline to take courses. So all medical schools are shut down. Again, this is very shameful experience that the students decline to get classes because of this policy. I don't know. I mean, I think that the medical education should be changed to some extent to emphasize the legal issues, policy issues, ethical issues, and trust issues. I think. I mean, sorry. Other than that, I don't have any clear answer as an economist.
Well, thank you for sharing those views on this very important and controversial question. Thank you also to Gi-wook Shin and to Lisa Lee for helping with organizing, and to our medical students for sharing their views, and thanks to all of you for joining us. We hope you found this discussion useful in understanding the issue. Thank you, and good evening or good morning.
Thank you.
Thank you.
Okay.
Thank you.